Hi, everybody, and welcome. My name is Neil Seidman, and I'm the co-chair of the Public Education Committee for ADAA. That's the Anxiety and Depression Association of America. And our topic today is helping family members handle suicide. And our presenter is Dr. Kathariya Mokrue. Now we're going to be recording the webinar, so you'll be able to see it again on the ADAA website. And you should be listening to this through your computer's speakers, so you do not need a telephone connection. And if you have dialed in, please hang up and just turn up your computer speakers. So before we begin, I'd like to just say a little about ADAA, the Anxiety and Depression Association of America. ADAA was started back in 1979, and today it's the leading nonprofit organization in the field of anxiety and depression. Our mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, through practice, and through research. And we work to end stigma and to get the word out that these conditions are real, serious, and treatable. I want to invite you to visit the ADAA website. It's a great resource. That's adaa.org. And you can support ADAA by making a charitable donation on the website. Okay, so let's get started. Now, during the webinar, we want to invite you to type in your questions, and we'll have a Q&A period at the end of the presentation. On the right side of your screen, you should see a Q&A panel. There's a little field at the bottom of that panel, and when you click in it, you can type in your question. Then either hit your Enter key or click the icon. And only Dr. Mokrue and myself can see your question. So as we go, feel free to type in a question, and we'll get to as many as we can at the end of our presentation. So I'm really happy to introduce our presenter. Dr. Mokrue is Associate Professor of Behavioral Sciences at York College of the City University of New York. She's a licensed clinical psychologist with over 15 years of experience in private practice. She's director of the research program called Stress Less at York. Her areas of specialization include cognitive behavioral therapy, dialectical behavioral therapy, and mindfulness-informed approaches. As one of the very few Thai-speaking mental health providers, she provides services to the Thai community in the tri-state area, and she's an active member of the ADAA Public Education Committee. So now let me turn it over to Dr. Mokrue.
Thank you, Neil, and good evening, everyone. Thank you for joining us. Tonight, I hope to be able to provide you with some tips for when a family member has died by suicide, has attempted suicide, or has suicidal thoughts. What I'd like to start with is the very first topic with suicide. If your loved one has died by suicide, know that you are not alone. And just to give you some perspective, according to the Center for Disease Control, 41,149 suicides were reported in 2013, which was the most recent years that these statistics were available. And it is considered the 10th leading cause of death in the United States. And for all intent purposes, they also collect information about the different gender rates of suicide across men and women. And we know that men die by suicide at 3 times the rate of women. And generally, there is a consensus in the community that studies suicide is that the actual figures are likely higher. And this has to do with how deaths are categorized. You know, they can be categorized in 4 different ways. As accidents, natural causes, homicide, or suicide. And unless the cause is fairly clear. It isn't ruled as suicide. So in some cases, deaths that have been ruled as accidents may have the intention of being suicide. So the likely figure is probably a lot higher than what you're seeing here, which is already a startling number. Again, you are not alone. Each suicide is estimated to affect between 6 and 10 survivors, so leaving hundreds of thousands of survivors to try to make sense of something that is largely inexplicable. Yet survivors will try to shed light onto why their loved ones chose to end their lives this way. So I'd like to go over what research has indicated as risk factors associated with suicide. Why did this happen? And one of the most common risk factors that have been cited over and over again is a diagnosable psychiatric disorder at the time of death, meaning that many individuals who choose to end their lives through suicide are highly likely to have some form of psychiatric disorder. Now, some of these disorders may have gone undiagnosed, but in hindsight, in doing what's called a psychological autopsy, interviewing families and friends, mapping out their patterns in the days and weeks leading up to suicide, they're able to put together symptoms that is evidence that could be diagnosable. Now, the most common form of diagnosis are mood disorders like depression and bipolar. Now, other disorders are also part of the picture or presents a risk for suicide, and that includes schizophrenia, conduct disorder. All of these different disorders have very similar effects on how the person thinks, how the person behaves and feels, and often trapping the sufferers into thinking that suicide is the only option. And a big part of what initiates or what leads to these types of the decision to commit to die by suicide is the depression and sense of hopelessness. Now, for young people, substance use disorder or substance abuse is also part of the picture. Suicide is often an impulsive act that is lubricated by substance like alcohol or drug use. For older adults, usually as the health deteriorates, as there's more chronic pain, prolonged pain, decline in physical health, these conditions often contribute to suicidality. Now, it's very important to keep in mind that most people with these conditions do not take their own lives. So these conditions present risks, but not most people with these conditions do not follow through. Now, research also indicates that other factors might predict suicide. One is whether or not there's been previous suicide attempts. This is a strong predictor. If there's been past attempts, there's likely to be future attempts unless help is received by the sufferer. And also, we know that family history of suicide or family history of suicide attempts can also increase the risk. And this sort of works in a similar way as divorce, in a sense that if you come from a family where divorce is never ever heard of, it's something you're not likely to consider. But if it's known that there's suicide attempts or completed suicides, then it presents an option. Another mechanism or another way in which having a family history of suicide or suicide attempts may increase the risk is due to genetic vulnerabilities. Perhaps there's family history of similar or related psychiatric diagnosis, and that puts the sufferer at an increased risk for having some of these diagnosable mental disorders. So other factors that are more immediate include prolonged exposure to prolonged stressful conditions, like being unemployed for a very long period of time, or going through bullying at school, or being humiliated for a long time. So that's one immediate risk factors that can precipitate suicide. Acute stressful events can also increase the risk, and this could come in the form of a divorce, a breakup, a loss of a job. Another risk factor that you may have been hearing about is exposure to news of suicide. When the singer from Nirvana, Kurt Cobain, died years ago now, there was a spike in the number of suicides and a huge increase in the number of calls that crisis centers were reporting. And I know that a lot of people think about Robin Williams as another very high-profile person who recently died of suicide, and it remains to be seen whether the death of Robin Williams will have similar results. That data is still being collected. The last risk factor I want to just mention is access to lethal means. If your home, you have guns in the house, or you have lots of different pills that can potentially cause harm, these can increase the risk for the individual who already has the mindset to consider this option. Now, some of these factors may apply to one individual. Some individual cases, others won't. And hopefully knowing that these general risk factors, knowing that what some of these general risk factors are, can shed some light onto the why family members chose to end their lives this way. But certainly it's not going to bring that much comfort. It's such a painful aftermath that survivors often endure for years. Now, other questions that survivors often have besides why did this happen is whether or not they are grieving in a healthful way, whether the grief reaction is normal. So I'd like to spend some time going over some common grief reactions, and this encompasses feelings, your thoughts, mental distress, your behaviors, and some spiritual components as well. And more than any other forms of death, survivors of suicide's grief reaction is often more complex. Grief itself is already very multidimensional and complex. There's no one way to grieve, but surviving suicide, grieving as a result of deaths related to suicide, complicates it even more. And sometimes some of these reactions appear immediately. Other times, some of these reactions may be delayed, or for some people never show up at all. So keep that in mind. It's something that people often are very hard on themselves when they believe that they should grieve in a particular way. There's such a variety in how folks can grieve. So feelings, some reactions that involve feelings include feelings of guilt, blame, responsibility. These are very, very common and often found in higher levels among survivors of suicide compared to other forms of death. The guilt of could I have done something to prevent this, blaming one another, blaming each other, blaming themselves, sense of responsibility. Feelings of anger can also be part of the picture, sense of why did you leave me, why did you choose to end your life this way, sense of rejection, why didn't you include me, why didn't you let me help you. Sense of rejection can also be present. And for many, anxiety and depression are also there, in the sense that the deaths in this manner can shake the worldview of an individual. You know, what you might believe about life, what you've come to expect, have all been shaken in a terrible, terrible way. So it makes sense to have some anxiety and depression. Life as you know it, life as you come to expect it, is no longer what you expect, and that can really shake a person to the core. Believe it or not, relief may also be a part of the picture, and this is more common among sufferers who have chronic conditions, and the survivors were involved with the caretaking for a long period. And another feeling that I neglect to put up there is certainly a sense of shame, because suicide comes with a lot of different stigma, and the stigma really serves to prevent survivors from accessing help and believing that they are not to blame. So this is something to also be aware of, that shame can really hinder help getting. Now, with regards to thoughts and feelings go hand in hand, as well as physical responses and behaviors. Along with these feelings are mental cognitive distress, including sense of disbelief, I can't believe this happened, confusion, forgetfulness, or disorientation, which can contribute to survivors feeling like they're losing their minds or they don't have a grip on reality. But it's very common to feel out of sorts and not quite clear-minded in the weeks and months and periodically throughout the post period. Depersonalization can also be there, and this is a state where one feels disconnected from themselves, or they might experience their world as surreal. Is also something that's often reported. A question, could I have done something to prevent this? Thoughts that come back to this question. It goes hand in hand with the sense of guilt, blame, responsibility we mentioned earlier. And there's often magical thinking or illogical thinking where survivors may engage in highly illogical thought process. So even in, for example, in the cases where there's a clear-cut suicide with methods and everything that's been documented, perhaps the survivors might believe that there is some conspiracy that might be involved and the death is really a homicide, or the suicide may be another way magical thinking can play a role, can unfold rather, is if the person believes that the suicide's due to some diet that the person had been involved in years ago. So there's really not a lot of logic that supports this line of thinking, yet can be very much present. And of course, rumination or preoccupation with loved one's death or the circumstances around the death. Okay, now grief also involves behavior and physical responses, and some behavior and physical responses are very intense. It can feel like a serious health issue. Chest tightening, shortness of breath, gastrointestinal discomfort are some. Certainly sleep disturbance is a very, very common response that's been reported, either sleeping too much, sleeping too little, or having erratic sleep pattern in the days and weeks, sometimes months, for some years, and we'll talk about that. It's part of the picture. Appetite changes, so eating more, eating less, erratically. And of course, given that there's it's such a shocking way to die, and the shame around it more than other forms of death, surviving suicides can lead the person to isolate and withdraw from social interactions more. There's also the urge, the need to retell stories of the death, or sometimes avoidance of the death, but telling stories around the person's lives in the days and months leading up to it. There's also, it's very common to have searching, this kind of need to look for, to go to the sites and the places that the sufferers, the family members who died used to attend in ways of connecting and searching, trying to find meaning to the deaths. And what we call psychomotor agitation or aimless wandering, really not having kind of clear purpose to the movements, to how survivors spend their days. Now, spiritually, many survivors can question their faith, or they might try to search for meaning in the death. It's very common to question some fundamental assumptions that one has about life, about fairness, about what they've come to expect as the scripts, or as mentioned before, what you've come to expect and rely on fall apart. So spiritually, it could be shaken as part of the grief reaction too. As you can see, grief can take on many forms, and it's highly variable between individuals. So the question is, what can I do to cope? And with regards to feelings and thoughts, it can be comforting to at least recognize and remind yourself that all these feelings, the anger, the guilt, the confusion, are all part of normal grief reactions. Emotions, they tend to come and go, they intensify, they dial down, and knowing that emotions rarely stay in the same intensity for a prolonged period unless you're working to bring it up over and over again. It tends to dissipate if you allow it to dissipate, and it'll intensify during some points, but they rarely stay in the same level for indeterminate amount of time. So knowing those two things can be very helpful in accepting and not resisting, so that you're no longer fearful that it's going to be like this for the same level for eternity. Another very important idea to consider is radical acceptance. And this is the idea that it's radical and it's acceptance that is radical in the sense that it's very difficult to accept that you may never fully understand why this happened. Acceptance is difficult, and it's not something that you can do one time. It's not something you can decide, I will accept that this has happened, and it will just solve the problem of non-acceptance. It is something that you have to renew over and over again. You have to decide to accept over and over again. It's actually an active process and not a passive process at all. Each time the mind goes to search for answers that are not going to be there, radical acceptance involves redirecting the mind back to reality as it is in the moment. And that this relates to the being able to limit rumination and worry, because rumination and worry rarely gets you to a good place. It often can spiral out of control, affect your sleep, affect your how you feel throughout the day, and it's usually not advisable to kind of continue to ruminate and worry. Of course, there will be some rumination, but learning to limit can be helpful. And to do that might be useful to adopt, what we'll discuss in the next slide, adopt different approaches to try to help you to limit rumination and worry. And you have to be aware of, it involves being aware of, being mindful of the time you spend reviewing the narratives or other stream of thoughts that isn't helpful. The last item here is identifying thought traps or magical thinking. Recognizing when you're engaging in magical thinking or using faulty assumptions. So when you find yourself shoulding yourself, in a sense that you say to yourself, I should have known, I should have been there, or if only I had been there, if only I had listened, if only I had, so on and so forth. When you find yourself engaging in these thoughts, streams of thoughts, it's often not useful. And there's no guarantee that a different action can lead to a different outcome. This is the downside to having hindsight bias. It sort of makes you feel like you could have done something differently. But will it? Can it? So being able to challenge these thoughts. Another way to try to challenge these thoughts is through considering the costs and benefits of ruminating or subscribing to these distortions. If I choose to believe that I could have done something different, if I choose to subscribe to these thought traps, what are the costs of this? How is this going to help me? How is this going to move me closer to integrating the death into my life? If the cost outweighs the benefits, maybe learning to have being able to radically accept that, okay, this is not going to help me. I can actively try to redirect and limit when my mind goes in this direction. So this takes a lot of effort to identify the thought traps and try to challenge and redirect. And another way that one might try to deal with these not such useful thoughts is think about if someone you deeply care about, somebody you adore, you want to protect, if they are presented with these types of faulty assumptions, what sorts of advice would you give them? Would you encourage them to continue to punish themselves or continue in this line of thinking? What would you say to the person? So sometimes taking a step back and seeing yourself in the other person's shoes and see what kind of advice would you give to your loved one can help you to get unstuck from these thought traps. But these different skills, these different ways to cope require active engagement, requires intentional and purposeful direction. So being aware of it can be very helpful to be able to engage. And it takes practice, and it takes being on top of it. And you can't really be on top of it unless you take care of yourself in the following ways as well. This is what this slide will tell you. First, take care of yourself. All of the different coping responses, what you can do to cope with your feelings and thoughts in the earlier slide require a lot of resources. It can be taxing to recognize when you're engaging in these distortions and thought traps. It takes effort to recognize when you need to perhaps radically accept the reality or that you cannot find the answer to a particular question regarding the death. It takes a lot of energy. So how can you and where can you get this energy? Well, you have to take care of yourself. Practice self-care. Make sure that you are well rested, that you are taking in, balanced meals, that you're exercising. Because if your physical body isn't well nourished or rested, your ability to control your mental states or use the coping skills I mentioned earlier will be compromised, and it can potentially lead to a negative spiral. The second bullet here is to practice self-compassion. Be kind to yourself. This is a very, very difficult thing you've gone through, and it is something that you are going to have to deal with for a long time. And to take care of yourself, be kind to yourself, can go a long way. It can help you to be able to get on in some ways with different aspects of your life in the best way that you can. Try to integrate this loss in a way that allows you to function. But unless you are compassionate to yourself, it's going to be very, very difficult to take care of yourself. One suggestion is to consider meditation to help you to be aware of when your thoughts and feelings are starting to turn in a negative direction. And this way you can redirect your attention to more helpful targets. Meditation can be very, very useful in recognizing these maladaptive or not such helpful responses before it goes on for too long. The next one here is about recognizing that each person makes their own choices. And this means that you need to make choices that are best for you in dealing with where you are. And so this involves being patient with yourself, giving yourself time, anticipate that there will be setbacks along the way, particularly during anniversaries, like during holidays, birthdays, etc., can be particularly difficult. If you think you've been doing well and these setbacks are there, it is normal. It is to be expected. And if you can anticipate it, you're more likely to be able to adopt healthier responses to help you to navigate that better. Okay. One very, very useful thing to do is to try to seek support from fellow survivors. There are many, many different groups in different areas of the country. There's a resource number that I'll provide at the end that you can access to try to seek support. This is a place where you can tell your story, tell and talk about where you are, and many people find this to be very, very helpful. And the last thing here is about seeking professional help if your grief reactions exacerbate or do not remit over time. Now, the grief reactions, there's no really perfect time to end grief. Grief can last for months and years and decades, but it should go in and out, and it should oscillate. A healthy grief process often involves grieving oscillating between two modes, rather a loss-oriented mode where you are focused on the death and the loss, and then a restoration mode where you are focused on picking up your life again and try to address the tasks and demands of every day and try to create a life without your loved one, try to create an identity without your loved one. So a healthy grief process will vacillate between these two orientations. And if you find that over time this isn't happening and that you are not taking care of yourself, you are neglecting your duties and your professional life and personal life, then it might be time to consider professional help to provide you with more additional support, more specific to you. Okay, it's very important to try to address that and seek out help when you can. It's very, very taxing to imagine that to give into the shame and the stigma around this. This will keep you from accessing help. Now, so what are some responses that may not be helpful? Sometimes I find it useful to identify unhelpful responses, particularly if it's prolonged. The first here is isolating yourself. Now, as I've mentioned, because of the nature of the death, there's often stigma surrounding the nature of the loss. It's understandable that you may not want to be around others. So while retreating can be helpful to some extent in that it can help to conserve, reflect, and regroup, persistent avoidance of routine and the social world is not likely to help. You're more likely to ruminate and blame yourself and engage in a lot of unhelpful behaviors if you isolate yourself prolonged. Blaming yourself incessantly, neither will, neglecting health care, that's not going to be very helpful. Or expecting grief to follow a predictable path. I want to speak a little bit more about that. Some of you may have heard of the acronym DABDA, D-A-B-D-A. DABDA is an acronym for Dr. Elizabeth Kubler-Ross's stages of grief, and it stands for denial, anger, bargaining, depression, and acceptance. Elizabeth Kubler-Ross worked with end-of-life patients and developed these quote-unquote stages of grief to try to understand how individuals cope as they face their deaths, terminally ill patients. Unfortunately, her work has made its way into the mainstream world, and this has led many people to assume that grief must follow DABDA or this predictable path, and the goal is to reach acceptance. And I say that this is unfortunate because people often hold themselves to that and compare where they are in the grieving process to DABDA. And this is erroneous, as Dr. Kubler-Ross herself considered DABDA as different coping reactions that people can sometimes react with denial, and then they will never accept, or sometimes they will react with anger first, and then they will go into depression and so on. Grief doesn't unfold in a predictable way. So it's very important that you're not comparing yourself or expecting that you are to follow a particular path. So I just wanted to veer off on that a little bit because I see it a lot where patients are not only are they dealing with the pain of losing their loved ones to suicide, but also punishing themselves for not grieving the right way. Okay. Questioning yourself goes hand in hand with that. And the last unhelpful response here is to subscribe to unrealistic standards, the shoulds. Again, I should be at a particular place. I should be better about this now. I could have done X, Y, and Z better. And these types of thoughts tend to not be very helpful in moving you through the grieving process. Okay. So I know that the aims of this webinars also to discuss suicidal thoughts and attempts when loved ones have suicidal thoughts and attempts, and this is very important to consider as well, since in many cases of suicide, the family member may have had thoughts and prior attempts. So, in fact, if you look at the statistics that are available, which isn't very much at all, but a large-scale survey by SAMHSA has identified 8.3 million adults reported having serious thoughts of suicide in the past year. And these thoughts can come in the forms of an explicit wish to die, like, I don't want to live anymore, I wish I was dead, or expressing a desire to escape, I wish I could just disappear, I want to just go away, or expressing that life may be better if they weren't there, expression of feeling trapped or not being able to cope with unbearable pain. So there are a variety of suicidal thoughts and ideations. Now, the data also indicates from this survey indicates that young adults are more likely to have suicidal ideations than any other age group, but it's important to note that not all thoughts lead to attempts. In some cases, having the thoughts is shocking enough to the person for them to consider getting some help or making a change to address it. But for others, it can escalate, and they may try to follow through with changes in their behaviors or begin to make plans to complete the action. So it's very important that we recognize that thoughts don't always lead to attempts, and this is also where a lot of interventions can take place. There could be a lot of different help for the family member who might be having suicidal thoughts or ideations. Now, with suicide attempts, the statistics is there's been mixed bags. There's no formal method of tracking suicide attempts, and the CDC they do gather data on hospital admissions of what's called non-fatal self-harm injuries. These are individuals who acknowledge harming themselves and it did not lead to any fatality. Now, some of these self-harm injuries may be related to intention to end their lives, but some of these self-harm injuries are attempts at coping or could be motivated by other reasons. So we do have this data through the CDC, and in 2013, 494,000 people or so visited a hospital due to non-fatal self-harm. And this suggests loosely that there is a ratio of 12 to 1 for those who harm themselves to those who die by suicide. There's also been estimates that about 1.1 million people report a suicide attempt in the past year. So that number is not quite clear-cut yet, but we do know that many, many more people have thoughts than people who attempt, than people who do end up dying by suicide. Okay. Now, the trajectory from having suicidal ideation to attempt often involve behavior changes. And some of these changes are red flags to be aware of. The more behavior changes are observed, the more serious the thoughts may be. And some of the behaviors include changes in sleep patterns, isolating oneself, use of drugs or alcohol, or increased use if the person's already using, reckless behavior as in perhaps driving drunk, texting and driving and doing things to engage, invite harm, aggression, so perhaps putting themselves in a way that they could get into fights or violence, and giving away possessions have been identified as behavior change that could be related to an increased risk in suicide. When a person possessions, they're likely to be thinking that they try to tie loose ends to make sure that life is left the way they want it to be left once they go on and end their lives through suicide. So the more behaviors you can observe, this might be at the time to really get help. You should certainly intervene early, and we'll talk a bit more about that. So what are some common reactions for when you realize your family members may have suicidal ideations or attempts? And it's disbelief is certainly one. Disbelief. How can they do this? Why would they think that? Confusion. Why don't they value their lives? Shock. These are all very common reactions, excuse me, among family members. Don't they know how precious life is, how lucky they are? So these are some usual ones, as well as anger and fear. Anxiety may be part of the picture, particularly if one worries that their loved ones might try to do something, if they have thoughts, or if they've had an attempt that they might try to end their lives again through suicide. Certainly sadness and relief that if the attempt was there, that the attempt was unsuccessful. So, of course, relief is often overshadowed in the days and months and sometimes years following by anger and fear and anxiety. So these are some common reactions. Now, before we talk a little bit about what might be some helpful responses and unhelpful responses to having suicidal ideations or attempts, it might be worthwhile to take a look at some common myths about suicide. You might have heard some of these, but I think it's worthwhile to go over. One is that once you're suicidal, you'll always be. Once you are suicidal, you'll always be suicidal. Contrary to this myth, suicidal feelings do not have to be chronic, particularly if the underlying problems are taken care of. And since we know that a large number of individuals who completed suicide have undiagnosable or diagnosable psychiatric disorders, if the help is obtained, if the right kind of help is there, it's very, very, very possible to not feel suicidal anymore and to be able to have the right coping responses, to be able to handle life and see other options. Another myth is you shouldn't mention the word suicide. In the presence of a depressed person, it may motivate them to consider it. This is also not true. In contrary, asking directly, but with compassion, if you suspect that your loved ones might be considering suicide or is thinking of harming themselves, it's very, very comforting to the person to hear that you're not afraid to use that word. You're not afraid to open up discussion about suicide. It's such a scary topic for the person who has these thoughts as well, that to bring it up themselves might not be something they consider. But if you suspect and you use compassion and bring it up in a loving way, it can really engage in a healthy dialogue and perhaps get the right kind of help for the person, for the family member. So it is not something to avoid if you can do it with compassion. Okay. When a depressed person seems to be feeling better, they are no longer in danger of harming themselves. This is also a myth. When in the midst of a depression, often there's not a lot of energy, not a lot of will. And so when a depressed person feels a little bit better, if they're not, say if they're not under the care of someone and they seem to be getting better, they might just have enough energy to mobilize resources to perhaps follow through with an ideation. So this is not the time to relax and be okay. They're out of the woods. Particularly if they're not under the care of a mental health provider. It's still something to be aware of and be on top of. And the last myth I want to mention is only the weak or only the poor, only the mentally ill, etc., consider suicide. We know that all types of individuals consider suicide, all different cultures, all different age groups, and all different areas geographically. Suicide touches the lives of everybody in terms of the variety of individuals. So this is also another myth. So while you're keeping these myths in mind, here are some helpful and unhelpful responses. Okay. One is to be aware of your own emotional response. It's very shocking to find out if your loved one's considering or thinking about or has attempted. You are filled with disbelief and shock and anger and depression and fear. Very important to be aware of them. It's not a good idea to shut them down, but it's good to really be aware of them so that you can decide whether it is helpful to express this or not, whether expressing these emotional responses will detract from engaging with your family member or it's going to be helpful in engaging the family member. Okay, so try to remember that you have your own emotional response to check in first. Recognize that this behavior or having these thoughts is a serious cry for help. So express your concern and be willing to listen. Don't be afraid to use the word suicide. What I'd like to suggest to people and to patients and clients over the years is to present your loved one who might be engaging in, who might be having suicidal thoughts or changes in their behaviors. Present them with the evidence you collected. You know them, you live with them, you spend some time with them. You might be able to open a dialogue with listen. In the past few weeks, you seem to be more sad. You have been spending a lot of time on your own. I love you. I care about you deeply. And I wonder if something serious is going on, if you are think of doing anything to harm yourself. So present your observations and engage in a loving, compassionate way so that it invites the person to confirm, disconfirm, or react to your observation. And that is better than shutting down. The next helpful response is to restrict access to means. So if there are lethal means in the home or that the person can get to, try to eliminate. So remove anything like guns or knives or anything that can be used to harm if they're within the vicinity. The next slide is to encourage. If you present your concerns and you're listening, encourage the family member, encourage your loved one to get help. And this is often more palatable if you offer to accompany the loved one to the first couple of sessions or the first session at least. This can be less scary for your family member or the loved one if you accompany them. And the last slide here is to seek help for yourself if needed, particularly if you have difficulties with your own reactions, if you feel that your reactions may get in the way of engaging in a constructive way with your loved one. It might be good to talk over with a mental health provider or try to get some pointers or suggestions in how to broach this topic or how to deal with your emotions. Now, some unhelpful responses, and this will overlap with what I've mentioned with the myths. It's really not helpful to try to ignore the message or avoid talking about the possibility that your loved one may consider suicide or has attempted. Some people ignore the message or avoid talking about it because it's uncomfortable. Some people ignore the message or avoid talking about it because they do not want to stir it up again. But it's very important to acknowledge and open the door for constructive dialogue and invite help, them to get some help. Some people will minimize their pain by talking about themselves. So it's really, really try not to say, I know how you feel, or look what you have look at what you have to be grateful for. Or when I was your age, I had worse problems. Really try to limit talking about yourself, or try to convince them that life is worth living, or that suicide is sinful or wrong. If these are the reactions that you have, it might it might lead to your loved ones feeling more distant from you, feeling that you don't understand, and it can confirm what they might already be thinking, that life, that they're alone, and that no one can really understand the pain that they're in. So really try to not do those things. Some people assume that the behavior is manipulation, and again, I can't emphasize this long enough. A better way to think about this is that the behavior is a cry for help. That if your loved ones no longer want to continue living their life as it is, the goal in considering suicide is really to get rid of a problem or force a change as an option. So it's really more of a cry for help. And it's more likely that they do not have the adequate coping skills to be able to communicate their need or their pain. And this is why encouraging them to get help may be more constructive and can really help prevent the trajectory to a completion or to more attempts. So I want to just, I think we've run out of time. I want to just end there to allow for some questions. And I want to just say another word, a reminder that the causes for suicide is it's really difficult and very complex to pinpoint. As you've seen all the risk factors and so forth, and ultimately each person is responsible for their own choices. And there is help. There is help for survivors, for you, for those who are contemplating or have had a previous attempt. There is a lot of help out there that's available, and these are some of the resources that you can take advantage of. And one of these different resources should be able to connect you with the right place, the right form of help that's suitable for you. Okay, so I want to just end there and ask if we have any questions.
Yes, we have a question from the mother of a woman in her 30s. So this is the daughter. She has a diagnosis of borderline personality disorder. She has had 3 suicide attempts and a number of hospitalizations for suicidal intent. When she is dysregulated, she usually states that she will have to kill herself. She has a history of drug abuse. She is in dialectical behavior therapy, but she does not engage with it. She's living in a halfway house. So the question from the parents, what can, if anything, we do as parents to prevent what we feel is her inevitable suicide, or to prepare? And then the mother writes, I hope there is something beyond radical acceptance.
That is it's a very, very sad situation where somebody with a diagnosis of borderline personality disorder is already getting care and it's not engaged in the treatment. Dialectical behavior therapy is certainly one of the best treatments for borderline personality disorder. And it sounds like the mother is doing everything she can to get the right help, the right forms of help, and doing what she can to keep her daughter out of harm's way. Besides seeing if there is a connection, if there is a connection with the therapist, if there is sometimes that having the right connection may allow for more engagement. But besides that, and really understanding that everyone is responsible for their own choices ultimately, communicating your love, your concern in a consistent way, and really also kind of keeping tabs on your feelings about the situation can help a very difficult situation even just a little bit. But this is really the time to make sure you don't get burned out and that you can revisit all things you've been doing and communicate again your care, your love for your daughter. I think that's really very important to continue to do.
So what I'm hearing, a couple of points that you just made, I think are really valuable, and they were both about communication, so possibly having some good communication with the healthcare professionals involved, and then also communicating directly with the loved one and just letting them know that you do love them, and maybe that's the most that you can do.
Very tough situation when all the help, you're getting your daughter to connect it to all the help possible.
Mm-hmm. So we have time for another question. Okay. And I just want to thank the people that have the courage to write in these questions, and they are confidential. So here's a question from a woman. My husband committed suicide almost 2 weeks ago. I find myself completely overwhelmed with emotions when I think of moving on without him, and I immediately throw myself into a task, be it work or cleaning or organizing. Am I just delaying the grief, or is it helpful to be working and busy?
That's a great question, and I think this speaks to what I discussed earlier about assuming that grief has to follow a particular pathway, and that there's just one way to grieve, and grief has to be immediate, and working through it is the only way to resolve grief. And 2 weeks is really, really, really fresh. It's just almost no time at all. It's very important to keep yourself afloat and take care of yourself. And if right now taking care of yourself means keeping busy, cleaning, finding a purpose every day, and it's working for you, that's perfectly fine. I think as time unfolds and you find that you're not moving to integrating and restore in the restoration mode where you're starting to look at starting your life and integrating this loss into your life, then that's something to kind of be concerned about. But at this stage, it's perfectly fine to do what you need to stay afloat. There's no one way to grieve.
I think we have time for just one more question. Any thoughts on why men outnumber women 3-to-1 with completed suicides?
Well, there are a number of reasons that's been looked at in research studies. One is certainly men often choose more lethal means to end their lives. So deaths through more violence like guns or hanging methods, whereas women tend to use less lethal, less definite means like pills and so forth. So that's one way. The lethality of the means has often been used to explain the discrepancy between men and women. And the other is, quite frankly, men are less likely to seek help for not just psychiatric issues, but also physical health issues. And that certainly prevents problems from being addressed earlier. So those two have often come up.
We just have a minute or two left. Any quick thoughts on ways of addressing guilt?
Sure. I mean, guilt is can be very toxic if you don't keep tabs on it. Guilt will be there time to time, but like all the other emotions, they come and go. They increase and decrease over time. And if you are clear about you're able to identify some of the distortions you might have around the guilt and be able to challenge some of these distortions, it might help you to kind of be able to accept the situation or be able to accept where you are in dealing with the situation. And guilt, it can, just like anxiety and depression, can ebb over time.
Okay. Well, thank you so much, Dr. Mokrue. It was just a wonderful presentation, and I want to thank everybody for attending. We hope it was helpful. Please let friends and family know about the webinar series, and you can make a contribution to ADAA on the website. So bye for now, and we look forward to seeing you next time.
You will now be disconnected by the moderator.